major types of sleep apnea, one being obstructive apnea, where there's pharyngeal collapse, there is effort. The patient is trying to breathe, but they can't because of upper airway obstruction. This is a very common form of sleep apnea, especially here in the United States, where we have patients that tend to be heavier, et cetera. And then there's central sleep apnea. And this is apnea without any ventilatory effort and really is a central process, a neurological process. Shane-Stokes respiration, that pattern of kind of rapid breathing and then pauses, that's a subset of our central sleep apnea patients. And it's not as common, maybe about 10% of all patients have central sleep apnea. And then, of course, like everything in medicine, there has to be some that are in the gray area. And so there are mixed sleep apnea events. And so for the sleep docs, you're familiar at looking at polysomnograms, but for me in cardiology, it was new. So the top line is the nasal airflow. The next line is the thorax moving. Opposite to that, the abdomen moving. So you can see effort. And then you've got pulse oximetry in the pink line, kind of the fourth one down. And then of course the snorometer. You know, how loud is the patient being when they're breathing. And when I first saw this, I think Robin will be the one person to laugh. I always say I shocked that because as a cardiologist, when I see waveforms like that, I think torsade and I'm running in there with my magnesium, my calcium, and my defibrillator to save the day. But this turns out to be airflow, thoracic and abdominal movement. So this is an example of obstructive sleep apnea. Again, for this group, you're familiar, there's no airflow at the top, but you do see a fair amount of effort, both in the thorax and the abdomen. And then you see cyclical desaturations that kind of just follow the obstructive episodes when there's no breathing. And then on the bottom, you can see the snoring. Obviously, when there's no air movement, there's no snoring, and then there's loud snoring as the patient kind of has an arousal. And you can imagine that at each one of these obstructive episodes with desaturation, there's kind of a surge of adrenergic tone that not only arouses the patient, but kind of punches the heart a little bit in that way. Now, here's what central sleep apnea looks like. So for central sleep apnea, you have episodes of breathing and then literally no effort. Those no efforts are associated with absolutely no movement in the thorax or abdomen to speak of. But if you look at the bottom, you actually see that the desaturations are similar. So there's going to be an overlap in pathophysiology, at least in the mechanisms of injury to the cardiovascular system, because of desaturations that occur, similar to what we saw with obstructive apnea. So here are some common metrics in central sleep apnea. So there's the apnea-hypopnea index, broken down into mild, moderate, and severe. The AHI is the overall number of apneas and hypopneas per hour of sleep. The central apnea index is the number of central apneas per hour. And then central sleep apnea is defined when the number of central events are greater than obstructive events. And then you have similar measurements for the obstructive apnea index, and then oxygen desaturation index, and then the percentage of time that patients are in rapid eye movement or REM sleep. So how common is sleep disordered breathing in cardiovascular patients? Well, we know that really where probably the best data are is around drug-resistant hypertension. That patients that require 3 or more drugs to manage their blood pressure, nearly all of them, 80% of them have sleep apnea, the vast majority of which will have obstructive apnea. And interestingly, treating the sleep apnea also treats the hypertension. And that connection, that pathophysiologic link, is probably where we have the most data. Now, congestive heart failure is also unbelievably common. And Dr. Javahiri, who I've had the opportunity to work with him and his son, did publish a paper a long time ago. This was mostly in male patients at the Cincinnati VA. And 50% of them had sleep disordered breathing. And then you can see that even a third of patients with coronary artery disease or angina, or all patients with hypertension, have sleep disordered breathing. So this is pretty common in the cardiovascular population that we see. And if we look at just the central sleep apnea patients, the vast majority of them do have cardiovascular disease, with more than half having heart failure, and then another 18% having both heart failure and atrial fibrillation, and then atrial fibrillation making up another small portion. Now, there are some patients who have idiopathic central sleep apnea where we can't figure out why, and a small percentage of patients who are post-stroke, who have a central injury and then develop central sleep apnea. So how would you test for this? Again, in this audience, I think you're pretty familiar. But nowadays we have a home sleep apnea test, and you need a class 3 device, which is able to monitor not only airflow, but obviously you also need to be able to monitor abdominal and chest movement in order to differentiate between obstructive and central apneas. And we've gotten really used to sending devices like this to patients' home, having them connect themselves, and then ship it back to us. There's also obviously the in-lab polysomnograms that are done. And these again are much more intense in terms of having more channels and requires overnight monitoring the sleep lab. But sometimes when it's really complicated, this is really the only way to get to the bottom of what the sleep disordered breathing may be. So now, can we connect central sleep apnea and heart failure? Well, we know that central sleep apnea is due to a loss of neural drive to breathe during sleep. And throughout the night, patients will have hundreds of repeated cycles of oxygen desaturations and surges in the sympathetic tone. And this really disrupts the quality of sleep and the quality of life. So patients end up fatigued because they're not sleeping well. They end up with cognitive impairment, depression, and memory deficits. And we know that those really translate into clinical outcomes. So they're twice as likely to have a heart failure related readmission within 6 months, something that got the attention of my hospital. And their mortality rate is actually much higher if you have heart failure and central sleep apnea. But what's interesting is that most CSA patients go untreated because there really had been a lack of FDA-approved therapeutic options for this population. So here's some additional data from Dr. Javaheri just showing that the degree of central sleep apnea is associated with much worse survival. So the worse or the higher the AHI, the worse survival in symptomatic heart failure patients. And if we use different cutoffs of AHI, you can see that the median survival is significantly worse in patients who have worsening central sleep apnea. If you have severe central sleep apnea, then the mortality rate is actually extremely high. And this curve looks like, patients that have entered stage D heart failure, where their mortality is unbelievably high. It's 40% mortality at 5 years and 60% at 7 years. So when you're a heart failure doc and you see these types of associations, you begin to wonder whether if I can treat the central sleep apnea, will I change the outcomes of my patients? Will I be able to improve mortality? We also know that central sleep apnea increases the risk of heart failure readmissions. And so if you have CSA, you're much more likely to be readmitted to the hospital. This was an important observation for us at Penn because we started to think about, should we be screening for sleep disordered breathing in the hospital in our heart failure patients prior to them going home? The answer was yes. And we actually did a study where we showed that we could reduce readmission rates by treating the sleep disordered breathing in our heart failure population. Now, central sleep apnea is often undiagnosed in cardiac patients, and that's because they're unlike OSA, where there's a BMI cutoff. In many of these patients, they have low ejection fractions and more dilated ventricles, but they look like a lot of other patients that have heart failure. They have atrial fibrillation or a history of stroke. They're in and out of the hospital. They have arrhythmias. But what we notice at the bottom is that, they have someone who's witnessed apneas while they sleep. The patient reports that they wake up frequently. Oftentimes they tell us it's because they need to urinate from all those diuretics that I'm giving them. But actually, some of that nocturia is likely arousals from sleep due to their sleep apnea. And then once they're up, they're like, oh, I must have to pee, and they run into the bathroom. But actually, if we treated their sleep apnea, the amount of nocturia actually goes down. And then these patients really describe fatigue and poor exercise tolerance. And so if someone comes into clinic with these features in a heart failure clinic, they kind of look like a lot of other patients. And it's really important for us to take a good sleep history, ask about apneas, ask about arousals in the night and nocturia to really help us drill in to those patients that might be at higher risk. Now, what about treatment of central sleep apnea? Well, we're fortunate in that there's a series of clinical trials. What we're not so fortunate about is that the trials didn't always answer the questions the way we expected. So this is the CANPAP trial. It was a randomized controlled clinical trial that involved 258 heart failure patients with central sleep apnea. And they were treated with either CPAP or control. And the primary endpoint was a pretty robust one. It was death or heart transplantation, so a pretty hard endpoint. And then many secondary endpoints: transplant-free survival, change in ejection fraction, exercise capacity, and quality of life, and then also changes to neurohormones. And so patients were randomized into this clinical trial. And unfortunately, for CANPAP, there was no change in mortality or heart transplantation. So the primary endpoint was actually negative. And I have to say, having done some research in this field, we were pretty disappointed by this finding, but not totally surprised. One of the reasons why we were not totally surprised is because the clinical experience was that a lot of these patients who required relatively high pressure CPAP really were uncomfortable and struggled to tolerate it. And so the compliance was not so great. We also noted that some of these patients had some hemodynamic intolerance to CPAP. We've seen this once or twice where their blood pressure falls. And so we really did worry that perhaps this modality of treatment, CPAP itself, may not be the best choice for patients with central sleep apnea and heart failure, or even central sleep apnea alone. One other concern was, were we triggering hyperventilation in patients with Cheyne-Stokes who were on positive pressure ventilation? Now, there was a post-hoc analysis of CANPAP, and what's interesting is that in the patients who actually tolerated the CPAP and wore it regularly and really suppressed their apnea-hypopnea index, what they found is that there was a significant improvement in transplant-free survival in patients who were compliant and then received benefit. What was interesting is that at least the conclusion here was that, oh, the treatment of CSA may be able to reduce mortality, which was really the holy grail for the heart failure docs and cardiologists that were interested in this area. The downside of this is that this was a post hoc analysis, and we all wondered in the back of our mind, were the patients who tolerated the CPAP maybe a little less sick? Were they somehow more compliant? Were they more likely to take their meds and exercise and do other things? Were they less likely to be depressed? Were they more motivated? And so this raised a hypothesis that this may be a good thing to treat, but I'm not sure any of us were convinced that the treatment modality was the correct one. So this leads us to Adapto-Servo Ventilation. This was a product that I was involved in the original clinical trials. This trial started to enroll patients during the CANPAP trial. And what's cool about this device is that this is a CPAP-like device, but it has a sensor in it that automatically adjusts the magnitude of pressure support breath by breath. So if the patient's not breathing, there's an apneic episode, the device literally acts as a servo ventilator and breathes for them through that period. But when they're hyperventilating or breathing on their own, the pressure quickly drops down and the patient's able to breathe kind of independently without us over breathing them. And so the thought was this would be much more physiologic and that this would work more like pacemaker technology, right? If you have someone who has bradycardia or has pauses in their heart rhythm, the pacemaker can be programmed to kind of pace them through those periods of time. Patient remains kind of unaware that that even happened. That was our thoughts around Adapto-Servo Ventilation. And we thought, oh, this device will be much better tolerated because we won't be pushing high pressure on their face continuously. And oh, this device will be much more physiologic and that will really help us. And so the small pilot trial that we did in the US showed that the device was relatively well tolerated and seemed to be safe. And that led to a much larger clinical trial called SERVE-HF. This was a clinical trial looking at central sleep apnea patients with heart failure, randomized to Adapto-Servo Ventilation or control. They had to have an ejection fraction less than 45%, and they randomized a lot of patients, 1,100 patients. That's pretty amazing. And again, like CANPAP, they were looking at all-cause mortality or heart failure hospitalization, and then had a series of secondary endpoints. This trial was done exclusively in Europe, and there was a lot of excitement and enthusiasm about it. Unfortunately, it didn't turn out the way we hoped. So what we found in SERVE-HF is that actually there was a worsening of outcomes for patients who were randomized to the Adapto-Servo Ventilator group as compared to control. And this was time to death, LVAD placement, appropriate ICD shock, resuscitated sudden cardiac death, or unplanned heart failure hospitalization. And so there certainly was a trend towards worsening outcomes, and definitely not anything that showed a benefit, at least in the whole group, for this primary endpoint. And then when we looked at death from any cause, there was actually a concern about a mortality risk of treating patients with ASV as compared to those that were randomized to no treatment. And this led to a lot of concern. And then the same was true for death from cardiovascular causes in the trial. It was even a little bit worse. And so if we look at kind of the incidence of the endpoint events, it was death from any cause or cardiovascular deaths that were significantly increased in the patients that were getting Adapto-Servo Ventilation. So SERVE-HF, which I have to say personally, I was very excited about because, you know, when you're involved in the development of a device and you've tested it in pilot studies and all that, it becomes, you know, part of your DNA. And it was disappointing to me to see that ASV did not turn out. So the conclusion of the SERVE-HF trial is that ASV had no significant effect on the primary endpoint of patients with CSA and heart failure, but all-cause and cardiovascular mortality were both increased with this therapy. And so, you know, we suddenly saw the withdrawal of ASV in the United States from many patients who had ejection fractions under 45%. For those that had normal ejection fractions greater than 45%, then they were still theoretically candidates for ASV. Now, this technology is made by more than one company, and so there's a second clinical trial called Advent-HF. This was looking at both CSA and OSA patients with heart failure. Again, EFs less than 45% on appropriate medical therapy. They started in April of 2010. They were expected to complete in June of 2020. When I was preparing for today, I went back to clinicaltrials.gov to see, did they complete or not? It looks like the trial is still open to enrollment, so I think they may have been a victim of some COVID activity. And so I don't see that the trial is actually completed. But they had enrolled over 600 patients by mid-2018, and I think it was actually closer to 720 or something when I looked it up. And they have published a paper that showed that compliance with the device, the ASV compliance was really good, and it was significantly better than what we saw in CANPAP, where patients really struggled to wear traditional CPAP. And so we're waiting on the results. What I will say is that they have been forced, because of the safety concerns from SERVE-HF, to do Data Safety Monitoring Board reviews. There's been 5 reviews of this clinical trial. I confirmed that again today. And the decision was made to continue the study. So at least in this population with this device, there does not seem to be a safety signal. Whether there's a benefit to treatment, we still don't know the answer. And so, not to say a pun, but we're holding our breath to find out what the outcome is going to be from Advent-HF. So that brings us to the newest treatment for central sleep apnea, and that's the phrenic nerve stimulation. So this is a fully implanted treatment for moderate to severe central sleep apnea that actually stimulates the phrenic nerve, so it really restores physiologic breathing as opposed to positive pressure, which is not really physiologic breathing. And the system can activate automatically at night, so it's really a passive therapy. So unlike ASV or CPAP, the patient doesn't have to do anything like put on a mask or remember to bring it with them or whatever. We can program the device like a pacemaker to come on at a certain time and know when the patient is lying down. And so it's really a passive therapy once it's in. And so they can be treated nightly without a lot of effort on their part. The device is implanted by cardiac electrophysiologists. I saw a couple, at least in the survey at EP docs. The procedure is similar to putting in a CRT or an ICD. The neurostimulator is implanted either in the left or right upper chest. And then there are 2 options for the stimulation lead. One in the left pericardiophrenik vein or in the right brachiocephalic vein, depending on the patient's anatomy or if they have other devices, et cetera. This is what the device looks like implanted. So there's a sensing lead as well as a stimulation lead, as well as the box that you can see that looks similar to a pacemaker or an ICD. And here's what it looks like. So if you, on the left panel, you'll see that with therapy on, breathing is pretty regular throughout the entire time period. And then with therapy off, you can see that the patient develops Cheyne-Stokes respiration with pauses and significant oxygen desaturations at the beginning. So with therapy, the device completely got rid of all of the central apnea, at least on this tracing. But with it off, we could restore the presence of central sleep apnea. So we know that it's effective, at least in that one case. So that brings us to the pivotal trial that was done here in the US and abroad. It was a prospective, multicenter, randomized controlled trial. Patients had to have moderate to severe central sleep apnea based on a PSG that was scored by a blinded core lab. They had to have pretty significant central sleep apnea. AHI is greater than 20. And then our endpoints were the primary effectiveness endpoint was comparison of the proportion of subjects that had a greater than 50% reduction in AHI between treatment and control. And then the safety endpoint was freedom from serious adverse events associated with the implant, et cetera. And then a series of secondary endpoints, which were hierarchical, which means that if you meet the first one, then you can go on to the second one. If you meet the second one, you can go on to the third one. And you can see there were a series of mostly sleep associated secondary endpoints in this clinical trial. This is how the trial was done. Every patient was implanted with a device. Half were randomized to therapy off at the beginning, half to therapy on. The patients were followed for 6 months where we assessed the primary effectiveness endpoint, again, with half of them on, half of them having a device in, but the therapy not turned on. Now, at 6 months, we turned on the therapy for everybody, and then we were able to follow that cohort out to 12 months, and actually well beyond 12 months, now out years, to see whether or not the effects are durable over time and how outcomes may change. This was the baseline demographics for this trial, very similar to the other trials I showed you. They're 65-year-old, mostly men, because central sleep apnea is much more common in men than women. They were not skinny, but they certainly were not hugely obese. Ejection fractions, this trial did not require patients to have a low ejection fraction like SERVE-HF and CANPAP and Advent-HF. But a lot of the patients actually did have heart failure. About 66% of them had heart failure. Atrial fibrillation was common, which we know is a common comorbidity. And again, a lot of the patients had concomitant cardiac devices because they had low ejection fractions. And then you can see that they had pretty severe central sleep apnea and an Epworth sleepiness scale that also showed them to be pretty fatigued during the daytime. And this was the primary endpoint of the trial. There was efficacy in terms of a significant, highly statistically significant improvement in AHI in patients that had the device turned on as compared to our control group. And then each of the hierarchical secondary endpoints were also positive. And so we were able to analyze all of them, showing us that quality of life improved as well as several other sleep parameters. So a highly effective therapy in terms of efficacy for treating the central sleep apnea. And if we look at reductions over time, you can see these are patients who are improved from baseline versus worsened. At the 6-month endpoint, 88% of the patients demonstrated a decrease in the number of apnea and hypopnea events at 6 months. And then when we looked at the entire cohort, now all of the patients out to 12 months, 91% of them had a significant reduction in apnea and hypopnea index at the 12-month time period. Now, our primary safety endpoint was also met, so 91% freedom from serious adverse event. The implant metrics for our electrophysiologists in the audience, 97% of the implants were successful. One of them at Penn was not because of a patient with prior infection and whatnot, and lots of scar. The lead revision rate is similar to what we see for BiV pacing. And interestingly, over time, the implant time, like we've seen with BiV pacing and other devices, trended down, but there is certainly a learning curve. The good news was there were no deaths related to the procedure, the system, or therapy. And this becomes a critical point because remember, while we're in the process of closing out this trial and just about done, the results of SERVE-HF become published that there's a safety concern. And so obviously our data had to be reviewed very carefully as we're continuing with the trial. And there did not appear to be any safety issues, and we moved on with the trial. We also showed that phrenic nerve stimulation really improved quality of life and that patients were really satisfied and actually willing to have the procedure again, which is important because we're asking patients to kind of undergo almost like a surgical procedure to have the device implanted, but they felt that their benefit far outweighed any concern or any discomfort they had from the procedure itself. In this first panel, you'll see that on treatment, the Epworth sleepiness scale number went down. That's actually an improvement in daytime sleepiness. 79% of the patients had an improvement in their quality of life. And then again, 96% said that they would undergo the procedure again. If we look at what happened between the treatment and the former control group, so the group that had the device turned off for the first 6 months, and then we turned it on and followed them, they looked exactly like the patients that had the device turned on right up front. So that was very validating in terms of the efficacy of the device. And then again, they had very similar improvement in quality of life. You know, we always worry when we place a device, is there going to be a big placebo event, a placebo effect? And in this case, we showed that no, turning on the device is really what was driving the improvement in quality of life, as well as obviously the improvement in apnea and hypopnea index. Now, we do have data out even longer than 36 months now, which I'm sure Robin can comment on. But what we showed here is that, you know, patients had ongoing a benefit from the device out to 36 months and beyond. And that's very reassuring that the efficacy of the device is persistent, because we hope, at least as heart failure docs, that that's going to help us then remodel those ventricles and hopefully move on to improved outcomes, which is really our hypothesis. You know, that's what we're hoping to see over time. And so knowing that the device, you know, you don't lose the efficacy over time with phrenic stimulation, something that people were worried about based on older data, we certainly did not see with this device. We also did a post-hoc analysis looking in the heart failure cohort on changes in ejection fraction, time to first heart failure hospitalization, time to cardiovascular death in the heart failure population. And what you'll see is that from baseline to 12 months, there was an improvement in ejection fraction. You know, this was seen in pilot data for CANPAP and for the ASV device, that the ejection fractions go up a little, similar to what we see when we start a beta blocker. And so we wondered whether improved adrenergic tone, not so many surges of adrenergic tone, would that improve ejection fraction and lead to positive remodeling? And again, this is hypothesis generating post-hoc analysis, small number of patients, but definitely intriguing that there's a benefit. And then when we look at time to first heart failure hospitalization, we see that in the treatment arm, that they were much less likely to be hospitalized for heart failure. And then we didn't see really any change in mortality, although we weren't powered for that. But thank goodness we didn't even see any trend in that direction. You know, I will say that we did a trial in obstructive sleep apnea and heart failure patients in the hospital, and showed that those patients that we treated, very similar results, much less likely to be readmitted. And that really triggered our hospital administrators, who are worried about their 30 and now 90-day readmission rates, to invest a little bit in the sleep program inpatient to help us get these patients screened, and then on the way out the door treated with an auto-titrating device to treat their obstructive apnea. I wonder if there's not going to be a similar call for central apnea, that really treating it will drive heart failure outcomes and be beneficial to treat aggressively. So central sleep apnea contributes to a harmful progression of hypoxia, arousal, and sympathetic activation. There have been few treatments for central sleep apnea and little randomized data until recently. And phrenic nerve stimulation offers a new therapeutic option for the treatment of central sleep apnea. We know that sleep apnea is associated with increased adrenergic tone and inflammatory markers, and this in turn leads to increased incidence of cardiovascular disease and ultimately cardiovascular events. Studies have shown us that treatment of obstructive sleep apnea can increase the cardiovascular disease and may decrease events. And now, although treatment of CSA is a little bit more controversial, it appears clear that the novel phrenic nerve stimulator is a promising new therapy. It appears safe and has efficacy against the sleep apnea. The question will be, will we translate that into improved heart failure outcomes? So thank you so much. I'm going to stop sharing. Oh, a few more people popped on, and I'll be happy to take any questions that people have.
Quick question, if you can hear me.
Yep, we can.
I can hear you.
Hi, Carl, calling from Michigan, electrophysiologist. Thanks for a great talk. Just curious about something you said very early on, in that you had some luck in motivating the hospital to take a look at apnea on inpatients admitted with heart failure. First of all, how did you do that? Did you just use a home device and place it on the patient while they were hospitalized? And how did you make that part work? Because it sounds intriguing.
Yeah, so we actually did do exactly that. We have a home-based device. Our respiratory therapists that are based in our heart failure ward. We have 2 floors in the hospital that are kind of heart failure specific floors that handle our VAD and transplant and heart failure patients. So the respiratory therapists that support those floors place the devices. They're picked up in the morning by one of the sleep technicians who come by the room in the morning and scoop them up. And then they're read. And then hopefully that night, sometimes it's the next day, it's not always that quick. If they are positive, then we set them up with an auto-titrating CPAP device. If they're going to be in the hospital for a couple more days, the DME will deliver it to the hospital and then they'll go home with it. If not, we have it delivered on the day that they're discharged home. And then they have sleep follow-up within a couple weeks of discharge. They download some information from the auto-titrating device and then kind of go from there. And we published a paper actually looking at the outcomes, and we showed that we could reduce heart failure readmissions and actually improved quality of life of those patients that received treatment of their sleep apnea. And that really got the hospital excited. And so now we do have kind of a permanent sleep screening program in the heart failure unit. And our clinicians can order that. The big fight that we have is that you want people to be more compensated. So you want them somewhat diuresed and kind of close to being ready to go home with their meds titrated. Doing it on the first night, you know, when they're really having orthopnea and PND is probably not the way to go. So sometimes we fight about timing, but we are able to do sleep studies now 6 nights a week. They don't do them on Saturday nights, but they do them on Friday nights, and they now do them on Sunday nights for us. The ones that are done on Friday nights, though, are not read until Monday. So that's kind of the gap. But it does work for us. The sleep studies in the hospital are not reimbursed. So that's the cost that the hospital has to eat, and the sleep program on the professional side had to eat that. But we are generating sleep consults on the outpatient side. So they are getting visits and whatnot and supporting the sleep program in that way. And if they have some unusual sleep disorder that they can't figure out from the home study, then we set them up for an in-lab study. That doesn't happen that often, but it does occasionally happen. So it does kind of drive patients into the sleep program that might otherwise be resistant, but since they're in the hospital and we're making it so easy, most of them agree to go ahead with the sleep study in the hospital.
Wonderful, thank you.
Hi, this is Sama. I'm one of the sleep medicine fellows at the Cleveland Clinic. My understanding is that the patient who was set up with AutoPAP like this with before discharge, they don't have very good compliance in the outpatient. So how that translates into decreased readmissions and all that?
So that's great. So this is an excellent example that technology alone will not solve your problem. So our sleep program actually has a nurse practitioner who kind of connects with all new PAP patients and does a whole bunch of compliance education and cajoling. And then one thing that we learned as cardiologists is we make the sleep important to the patient. So we go in there and say, wow, you have sleep apnea. Boy, people that have sleep apnea are much more likely to die of their heart failure, much more likely to have arrhythmias, ICD shocks. They're much more likely to have progression of their heart failure. So, you know, we talk about treating all of you. And I do say this to patients, you know, medications are one therapy, devices are one therapy, lifestyle, exercise, etc. Sleep is one of those components. So when we think about all of that and really being comprehensive in your care, the sleep is important. So we've done studies where one of us as a cardiologist goes in and says to the patient, this is important. We actually stole that from the smoking cessation literature. You know, if you go in when someone's in the CCU right after the MI and say, smoking caused this, they're much more likely to quit smoking because you kind of really connect the behavior with the outcome. We've tried to take a similar tact. So on rounds, if someone screens positive, the heart failure attending goes in there and discusses that with the patient and tries to connect it to their heart failure. And then they get phone calls the day after their discharge and 3 days later or whatever. There's a whole protocol. And we actually had pretty good compliance. What I will say is that our early compliance was excellent over the first few months. What's been frustrating for me is that people do fall off after that. So we had good early compliance because we had a lot of effort. And then some of those patients kind of fall off the bandwagon. And so it goes to show you that you have to continually kind of remind them as their follow-up in the sleep center gets more spread out. They see us in the heart failure program much more frequently. So we inquire about their CPAP utilization, any problems with the CPAP at every visit. We kind of make it like it's another medication on their list. My staff is not so good at troubleshooting the CPAP, and neither am I, but we have a hotline number to the sleep center. So if a patient reports to us that they're having trouble, our staff will flash a message either through the chart or phone call, and then the sleep center follows up with the patient the day after their visit to kind of troubleshoot their CPAP. So we do have a good kind of airtight system, but we've noticed that after 3, 6, 7 months, sometimes some of those patients fall off the bandwagon a little bit.
Thank you so much for your answer. And a follow-up question to that is, one, you said the sleep nurse practitioner, does she see the patients before they are discharged? And second, in the future, do you think like in cardiology, heart failure, telehealth inquiring, like, giving a patient a call and inquiring them about their fluid status and LASIX and all that, that is shown to reduce readmission. Do you think in the future, this central sleep apnea or CPAP compliance questioning or motivating patients about that will also be part of that telehealth call or something like that?
Yeah, so those are both awesome questions. So the patients are seen by a sleep fellow and a sleep attending in the hospital, and that visit is billable. And it also gives the sleep fellow some inpatient, which apparently there's a small percentage of their time that they have to do that. So we partnered with the sleep fellowship program so that those patients do get a consult in the hospital. So the nurse practitioner that calls them is not seeing them, but they are seen by a sleep faculty member and fellow. And when possible, some of the sleep guys don't do as much clinical and they're more researchers when they come on inpatient. But when possible, the sleep doc that saw the patient, either the fellow or the attending, will see them and follow up in clinic. But many of them will not meet that nurse practitioner until they show up to clinic, weeks after their discharge. And then the second thing is, should we incorporate it into our telemedicine? And the answer is yes. So in clinic, we have incorporated asking about CPAP routinely. When my staff is calling, when the heart failure program is doing the disease management, we can do that. But when we have it farmed out to our home care telemedicine, which follows about 600 people at a time, the questions are super focused, and we haven't gotten them to ask about sleep yet. So I think that's the next frontier for us. The nurses in my practice, they're very aware of sleep and that we care about it as docs, and so they kind of are, routinely ask patients about it, but our regular telehealth does not. So I do think that's a target for us.
Thank you so much. That answered my question. Appreciate it.
Well, while we're waiting, if there's any more questions, I do have one other comment, just thinking about EP. We do have another niche program at Penn. It is not my program, but our AFib ablation program actually started doing a formal sleep screening for those patients coming into the AFib clinic. Frank Marshalinski's group has really been at the forefront of kind of figuring out AFib ablation, and a lot of patients come in for that. But we saw that the success rate wasn't as good in the patients that had sleep apnea that was untreated. And so suddenly EP was very interested in screening sleep because they wanted their AFib outcomes to be the best in the country. We're competing against the Cleveland Clinic. We got to make sure that ours are the best. And so they started a niche program, and they cross-trained 2 of the EP NPs, went and hung out in the sleep clinic, and now come back. They screen the patients using a questionnaire, and they kind of talk it through with all that. And they actually order and send them out the home sleep thing, and then it gets scored, and then if it's positive, then they actually get a sleep consult and treatment before their AFib ablation. And it's amazing the number of referrals. It was like saving the day for the sleep program, that a huge number of these patients have sleep apnea, which is no surprise to us clinically, but no one, the AFib and the frequent hospitalization, no one was paying attention to that as a risk factor. And so suddenly our EP guys, who are like a factory, were doing this kind of routinely, and it really generated a lot of interest. And they've started publishing their data, similar to the heart failure program publishing its data with sleep. So there's actually 2 cardiology, what we call niche programs in the sleep program. They have one in bariatric surgery, they have one in the stroke program, and they have 2 in cardiology. So there's kind of a lead physician on the sleep side and a lead physician on the cardiology side for each of those programs. And they've been really successful. And we created an Epic order where they just click a single button, and heart failure too, we place an order and it automatically, like, they get whatever they need. Me as a heart failure doc doesn't have to blink. And that's really helped us. And I think we've learned a lot about kind of how to manage the sleep and how it impacts kind of reducing the cardiovascular risk. So that's not exactly what my focus was tonight, but it is kind of in this general field about screening people. And every once in a while, one of those patients screens positive for central apnea. So Jorge Mora, one of my colleagues in the sleep program, and I were actually meeting this past week discussing how do we capture those patients and make sure that they're getting treated for their central apnea when they're picked up on the screening in the other program, in the non-heart failure program. So we're trying to figure out a good clinical path to capture those folks.
So, any other questions?
Yeah, Lise. So you screened a ton, I know, in your heart failure clinic, and what kind of questionnaires are you using? Because we get a lot of debates on that, on which is the right one, what's the cutoff, and how portable is it, right?
Yeah, so I can tell you that we have our own homegrown thing that we use. So I have no validation data whatsoever. So I'm coming clean. We actually have a series of, so we have a very large multi-year kind of heart failure biobank at Penn. So when patients are referred into the heart failure center, they fill out this unbelievably complicated questionnaire, which people look at us and say, we can't believe that people fill it out, but they do. They actually come back, most of them. And it asks them all about their history and their family history and all that, and we're screening for genes. Hidden inside that very large new patient questionnaire are several questions regarding sleep. It asks them, do you know that you have sleep apnea, yes or no? Have you ever been treated with CPAP? Then it asks about snoring, about daytime somnolence. It asks about witnessed apneas. And then it asks about nocturia and arousal. So that we kind of just ask them outright. It's almost like a free text. They can fill in what they want. And then that screening questionnaire is actually reviewed at their first patient visit. The nurses do a quick screen and review of the sleep. It's one of the components that we do in our kind of initial intake. And then the physicians do it as well. If they screen positive, then we have a button in Epic that we press and says this patient needs a sleep referral. Our sleep center has been super flexible. So what they do is, say the patient doesn't live in our service area, like there's no way they're going to come back to Penn for like an in-lab study, but even not, they will actually refer them to a program in their area, even if it's not one of the Penn programs. And then they'll follow up to make sure that they got it done and what the results were and get them back into our chart. So they've been actually pretty good about that. Now with home studies, we have a whole bunch of patients that say, oh, I'll come back to Penn for like a visit with the sleep program after my sleep study. I just don't want to like come downtown to spend the night, when I live 3 or 4 hours away in central Pennsylvania. So I think we've actually captured more of those patients in COVID times and with the sleep, with the portable studies than we were in the past, because it's kind of like the sleep center is doing a lot of their visits virtually anyway. So that barrier has come down, but it's a very homegrown, questionnaire, but it does trigger a lot of sleep referrals. And even in people who have been sick for years, no one addressed it. Or someone addressed it a long time ago. The patient's like, yeah, I don't want to wear a mask. And like no one really connected why it's important to treat it. And so I do think that we're, Maria Rosa is probably the most effective convincer of this, with her patients. But I think our group is probably the second most, because we really do try to connect the bad outcomes to the sleep and the heart failure. Like treating the sleep is yet another important thing we can do. And sometimes I say to the patient, look, it's not taking another pill. It's something different, and it may really have a positive impact. So that's kind of how we approach it.
And so to that note, what does it mean? Because sometimes I think we forget. Had the opportunity to listen to patients last couple of days, which has been really, I forget why I got interested in sleep. So I personally got interested in sleep because I had a young woman with flash pulmonary edema, ended up in the hospital and intubated 3 times at like 28 years old. Clear fluid on her x-ray. And after looking, couldn't find anything, no diastolic dysfunction, which is crazy. Heavy woman. I put her on CPAP It was all sleep apnea. She lost 35 pounds. She got pregnant. She had been trying for 3 years. She never, I actually would check on her once a year, but she had no need to see me because it was all flash pulmonary edema from severe from severe obstructive sleep apnea. So that was kind of my interest. And I always think back to her, but some of the stuff we see with these patients when you get them well treated these are patients that are really sick. And the impact on their lives. So I don't know if you could share anything about it's not just necessarily central, but just in general when you're treating these patients.
Well, I'll tell you that years and years ago, I shared a patient with a colleague at our sister hospital, which is just a few blocks down the street, literally in Philadelphia. And he had a gentleman who was very heavy, like 380 pounds, and was admitted multiple times, AFib, heart failure, had terrible obstructive sleep apnea, and was pretty non-compliant, and was sent over to us because their ER was like on divert, and he ends up on my service, but he normally was admitted to the other hospital. And we went through this whole thing with him, and his sleep apnea was so severe that the house officer on the heart failure floor got no sleep that night himself. We joked that neither the patient nor the house officer got sleep because the guy kept popping into VT or desaturating. The nurses would freak out, call the intern, he'd come out, the patient would wake up, it would go away. And this went on the first night. And we approached him about, trying to get onto CPAP, and he was unable, unwilling. It was really a nightmare. And then he developed almost like a hypercarbic respiratory failure, and got really fatigued in his heart failure and ends up being intubated. And long story short, we had trouble getting him off the ventilator, and he ends up with a trach. And this guy lost 90 something pounds he goes home with the trach, goes to rehab, comes out. I wasn't following him regularly, and then he came over to see me for a follow-up visit. It was months and months later. I didn't even recognize the guy. The trach had come out. It was amazing. And then it's an interesting story. I got a phone call from the guy who follows him at Presby, one of my partners, and the guy gets arrested for drug dealing in his community. Apparently that was his career before he became so obese and somnolent that he didn't get out of the house for 5 or 6 years. And then he had the trach, lost all this weight, got his life back. He looked fabulous. And then he ultimately ends up in jail. And then that was like the ultimate story. But I did say, well, at least he returned to his work. Like, could I take credit for that? So in our neighborhood, that's what his job was. But it is a little bit of a funny story. But I had never seen something so impressive as just the trach changed his life. And then he lost all this weight. His heart failure got better. He wasn't having arrhythmias. He didn't get readmitted. It was really remarkable. So I have the similar story to what you were talking about. We have other patients who've treated, like the patients that were in the clinical trial. We had several of them that their life was really significantly better. We have one guy with idiopathic central sleep apnea who's very thin and healthy and muscular, and his life was miserable with fatigue. He couldn't work. He's an engineer. It was put in the clinical trial, and his device, we just changed the generator. I mean, he's a guy, like, it's been 5 or 6 years, and he feels his quality of life is just dramatically better. So he wasn't as dramatic as coming in the hospital, but he noted that he just couldn't concentrate as an engineer on numbers and spreadsheets and doing calculations. And after we treated him, his mind was clear and he was able to kind of work. And so he's a true believer, just subjectively, in terms of how he felt.
That's great. I think it's just easy to sometimes forget that component. We get so tied up in data, at least I do. So, and lose track sometimes of what it really means to the patients. So,
agreed.
Any other questions? I know I talked a bit.
If no one else has questions, this is Osama again from Cleveland Clinic. I have 2 more questions. First one is for Dr. Goldberg. Dr. Goldberg, do you know, are there any randomized controlled trials in the pipeline for seeing the impact of remedy system on heart failure readmission? I know you talked about that was a post-hoc analysis but are there any clinical trials in the pipeline for that? And second question I have is for the Respicardi and remedy representative. Being a sleep physician, wherever I go after finishing my training, I'm interested in reducing heart failure admission. But how can I coordinate with how are you penetrating different heart or cardiology programs, and how can I set up a program over there, because I cannot like implant the remedé system. So how to establish that program?
So I'll take the first question, and then Robin would probably be able to chime in with even more information. So we do have a trial called the REST trial, which is a trial that's looking at outcomes of patients that get the device implanted commercially. So now that device is approved by the FDA, it's the only approved device for central sleep apnea currently. And there is a clinical trial, and we are tracking in the heart failure subgroup outcomes in those patients. And so a lot of us that are interested in this really want to know what's going on, and that may lead to additional trials down the road. But the observational trials are really important in this space because the numbers are relatively small. So we want to know kind of what the effect size is. We want to know how patients are impacted. Number one, I think that'll make a better case for us in terms of getting programs up and off the ground. But secondly, it really informs us in terms of which patients benefit. And then lastly, what other trials should we do, both pathophysiologic trials as well as kind of clinical outcomes trials. So we do have one trial that's ongoing. And then I'll turn it over to Robin to answer your other questions. And she may know in her mind of other trials that may be ongoing kind of with the remedé device.
Yeah, so so there is another, actually, I haven't even had a chance to tell you this, Lee. So the Biohousing group actually just published their commercial experience. They followed all of their patients, 24 patients now out, and showed some improvements in 6-minute hall walk test. So it's interesting data, still small numbers. One of the reasons that we haven't just, jumped into an outcome study is because the patient population that we're finding is really, I would say, markedly different than what I would have expected from the literature. So back to the trial you presented, only 64% had heart failure. Only about 30% looked like a served patient population. So we're finding that the patients that are actually, practically speaking, being treated in the US primarily are healthier. They're class 1 and class 2 patients. They're ambulatory. And so we need to understand the effect size before we would start jumping into, because we can't power anything yet, right? We're going to have more data to do that. Having said that, we have more and more centers that are getting up and running, and we absolutely would love to partner with you once you get out into practice. It starts with a call to the local area rep, but what Respicardia does in all our geographies is we build programs. So it may well be that one implanting physician can work with 2 or 3 different sleep physicians, but we'll work together. If you're in the same hospital, typically we'll build a program, at the hospital. But if you go out into private practice, which is something sleep physicians still do, or a small group, we would work with you to connect with one of the implanting physicians. And then typically the patients are coming back then to sleep medicine to be followed, especially if you have, a cohort of patients. So it's just getting in touch with us, telling us that you're interested. And then hopefully by that time we will have an implanter in a similar location. I heard the other day, we have 92 centers now across the US. So not almost every state now. So we are getting more broad than we were 2 years ago, and still fresh out. So hope that answers the question. Feel free to reach out to me, and I can, if you know where you're going, and I can help connect you with the right people as well.
Thank you so much. Definitely.
Well, Robin, I think
that's great. Yeah, no, I think that's wonderful. Lee, I can't tell you how much I appreciate it. It sounds like we have a great group of and diverse fellows that are on tonight. From specialties, from areas of the country. So I'm really pleased. I think the plan, hopefully going forward, will be that we'll maybe quarterly do educational. So first and foremost, Lee knows this, I love to teach, it's my passion. I still am on faculty in Oklahoma, so I make everybody at our company go to weekly grand rounds still. So, so we would love to create some great content and connect fellows across the country that are interested in this patient population, which, you know, makes up, you know, about 1% of the US population, right? It's a small patient population, but really associated with a lot of comorbid conditions. So our hope is that we focused on one specific therapy that we'd all learn together, because it's a really exciting field. We're learning a ton about the interaction between breathing and cardiac disease, about respirations and neurological function. And I think the research over the next 2 years that's going to come from this group will be fantastic and add to the literature. So Lee, thank you for coming and kicking us off. Always great. I always learn something from you, so I very much appreciate it. And again, if you have questions that you maybe didn't feel comfortable or didn't get to ask, please reach out and let us know, and we'll be happy to catch up.
Well, thank you so much. Thanks everyone for coming too. I appreciate it. Good night.
That sounds great. Good night, everyone.
Thank you. Thank you, Dr. Goldberg.
Thanks
You can
for
stay on
inviting
just a
me.
minute. Huh? All right.
Thank you.
Thank you, everyone.
Thank you.
Does our team have any questions? I know we have a few people from our team on. All right.
Not right now. Thank you.
It's a quiet group tonight, Lee. Thanks so much.
Yeah, it's a weird format with the Zoom. I think it's hard, and they didn't turn on their cameras, you know. So I got no audience feedback. I was talking to my
Just
computer in
me.
my dining room. Yeah, and then I ended up squishing it down because it was covering up some of the slides. So I really was like lecturing to myself in my dining room. But and my kids, I think, my kids learned a bunch about sleep apnea upstairs, I think. But
I would have had my screen on, but it probably would have froze. And it would have
yeah. You get special internet dispensation tonight. We got to send out, you know, we hate Comcast, but at least, like, I have to say, we had a lot of reliability issues in my house early on in the pandemic. Everyone was home, but, you know, both college kids, me, everyone was working from here. And I tried everything to troubleshoot. I swapped out the equipment and I had to call them, and they sent, I had a really hard time, and they have like a complaint line that I had learned about years ago that goes like to someone in their president's office. So I wrote this thing, and I'm like, dude, I've done all this like trouble. I've been on the phone for hours. I can't get the internet to work regularly in my house. And they sent like some special, you know, like higher end technician to my house. And there was some rusty thing on the outside of the house. Like the house is 20 years old. And he replaced something. And then he said, can I come in the house and replace something? And, you know, this was like the heat of COVID. But it turns out his daughter was at CHOP and was having an endoscopy, and the tech had actually had a COVID test the day before. So I said, fine. So we all wore masks in the house, and he fixed it. And since then, it's like unbelievable. So it was like the rusty screw.
Great.
Like he showed it to me. He's like, yeah, it's, you know, it rusted in the box or whatever. Totally fixed. But
Isn't that crazy?
We had it would actually drop you, and then you'd have to like log back in. You know, it was really terrible. So I can relate. And my family was mad at me every day. Like,